Greetings and welcome to AWHONN Insights, the home of candid nursing conversations. Today we're centered a new way forward with technology at AWHONN 2025 here in Orlando. We're delighted to welcome one of our long-serving members, Laura Scalise, the nurse manager of the postpartum unit at the Hospital of the University of Pennsylvania, and co-worker of mine. She is presenting Healing at Home, applying innovation principles to redesign and optimize postpartum care. I'm joined by co-host Lakisa Ballard, a clinical nurse education specialist in obstetrics and a member of the Maternal Mortality Review Team of Maryland. Lakisa, would you like to start us off?
Yes, I would. Good morning. Hello, Laura. So glad for you to be here with us. So we're going to go ahead and get started. Can you talk about some projects that you have been involved with that has allowed you to leverage technology to improve practice?
I sure can. So it makes me think back to around 2010. We were on as a bedside nurse on the postpartum unit at the Hospital University of Pennsylvania. We were just beginning to start scheduling patients, discharge postpartum patients with 2-week blood pressure check appointments. After doing that, we would have the patient would be discharged, and they would assume we would encourage them to schedule their blood pressure checkup. Lo and behold, they weren't, we found that they weren't able to schedule their appointments. They were forgetting, newborn baby, you're tired after you go home. So we thought, let's pre-schedule their blood pressure 2-week appointment. So we did that, and we gave them a little piece of paper with their little appointment in 2 weeks. And we thought, oh, they'll definitely show up at their 2-week appointment. They still did not show up on their 2-week appointment. So I thought, well, you know, let me try a reminder. Let me try texting them. And then people are like, well, I don't know if everyone has cell phones at that time. We have to think back. It's not the current state of everyone has an iPhone. So I would text them. I'm like, well, what the heck? Let's just try it. And I started texting them about their blood, how are they doing? Congratulations on your new family member. And lo and behold, they started to remember with the text that some of them would start making and coming back to their appointments. But they actually really loved that I stayed in connection with them. So that was actually the first project. I actually presented that at AWHONN in 2015. But again, let's remember they weren't able to show up at their appointments, but they loved how I had that connection with them after they were discharged.
I have a follow-up question with that. I love the text because it's nice to have a good old prompt. Was this from the hospital phone, right? So you guys had texting capability through the phones within the hospital system?
So at the time, so in current state, not sure of all organizations, but many organizations at that time, nurses weren't having cell phones to actually use for documentation. So at that time, I was in the assistant nurse manager role, so I was using my boss phone in order to text patients their reminders about their blood pressure appointments.
So that brings me to what was later become the Heart Safe Motherhood Program. So that can you tell listeners about what that program is and what challenges that program kind of overcame, and like what was your role in getting that started? I think that's what led to some of this work.
It sure did. So since we weren't successful with uh, reminding people initially to show up at their 2-week checkup appointment, for their blood pressure check. Now, this is not their 4 to 6 week checkup appointment. And then I tried texting them, and they love that I text them, but still couldn't get them to that 2-week blood pressure checkup. Then we thought, why don't we send home a blood pressure cuff? We'll teach them how to use it, and they can then text in their blood pressure, and then we'll have providers awaiting those blood pressure texts. And that's how Heart Safe Motherhood began, and my involvement with Heart Safe Motherhood.
So at the A1 convention here for 2025, you're presenting about Healing at Home program. Can you share with the listeners what this is and how it was developed?
Sure. So Healing at Home was an idea from Heart Safe Motherhood. So Heart Safe Motherhood, we were so successful with having patients text in their blood pressures. And initially, providers were answering all of those or addressing all of those blood pressures, whether they were mild blood pressures and within normal range, super, or if they were elevated, a provider would navigate the patient on what to do, whether it would be medical intervention, or they would have to come back to the hospital for additional intervention and treatment in-house. Having a provider at the other end of that text, with the multiple patients that we had texting in blood pressures was not sustainable. So in that Heart Safe Motherhood program, algorithm was developed to have an AI actually decide what blood pressures were good and which ones would need intervention. So we thought, well, this works for blood pressures. Maybe we can use it for other questions that patients might have after they're discharged.
So with the AI, and I know the physicians are the experts behind the AI to make sure it's giving relevant information. Tell me more about the authenticity with the patients sending in their blood pressure, because it could be where, I mean, we would want and hope that everybody's sending an honest blood pressure. Was there any discussion about patients who may not be sending in, oh, it's kind of high, so I'm going to send in this blood pressure versus sending the actual blood pressure reading?
Sure. So we initially, when we launched Heart Safe Motherhood, we used test patients. So I was a test patient. And we would text our blood pressures in, and many of our providers, and we even help patients also help being test patients. So both a provider would watch the blood pressure and then making sure that the AI bot, if you will, um, was also giving the same information back to the patient on what to do moving forward. So there was definitely a testing phase. And again, we used that same testing phase when we initially launched Healing at Home. Again, making sure you had a great question. We wanted to make sure that what the bot was interpreting um, would match exactly what the providers would encourage patients to if they needed intervention or not.
I'm going to do one little follow-up question. So, when you were talking about the Healing at Home program, can you tell me how did you get all that information into a bot? Like for the blood pressure, it's kind of easy, right? You blood pressure's high, low, elevated. You can do make a small. You're talking about everything somebody questions may ask postpartum, mother, baby. How did you go about like creating this whole algorithm of what these questions were?
Great, another great question. So we give out this beautiful folder of information, lots of paperwork, right? So we have a brochure, we have lots of paperwork, we have a news booklet. I believe it's 32 pages. At the time, it was 64 pages. So what we did, we just fed that into the bot or the algorithm. It's kind of like, I like to think of it as it's like a library. So we put lots of books in that library. Um, and then again, we went through the testing phase because we wanted to make sure the right books were in the library. So when patients, we would actually try to, it was kind of fun when we were test patients, we would try to quote, break the bot. So we would ask different questions in different ways in order for the bot, and we call her Penny, would answer in the correct form. So yes, we would try. And again, why we were testing Penny in that way, we were kind of putting more library books in the library.
So, as we know, our workforce unfortunately is not growing, trending upward. It is kind of getting a little tight. I do like this. I wonder how often is the bot tested? So, with that, and how often are you updating the library? We know references every 4 to 5 years, but how often is the bot tested for integrity?
Sure. So we didn't actually launch the bot, or we didn't launch Penny until she was over 90% accurate. And we knew that even though we tried to feed Penny all the information, we knew that things would come up along the way. So after if Penny couldn't answer a question, if we didn't have that library book in that library, we could create that book and then put that in the library. So I have the example of when a patient texted in about her swollen feet. We didn't have that content in Penny. So what we did, we quickly built it, and we used it. Penny uses natural language processing. So as we call her a bot, we didn't want her to be robotic. We wanted to have her simulate what a provider or what a nurse, the natural language you and I would use. So if a patient would text, we swollen or feet or swelling feet or swell feet. So we would put different types of terms that a patient could use if they had concerns about some swelling, if that makes sense. So we built the content in, and now Penny knows how to answer about swollen feet. To get to that answer, Penny uses prompts and different questions. Where's the swelling located? And then the patient would choose A for leg, B for arm, C for foot. So the Penny will take the patient through the algorithm in order to say, hey, this swelling seems normal, or hey, this seems concerning. Let me have a provider call you back with this.
So it's constantly evolving. That's kind of what you're saying. Like the more you questions you ask, the more that you go. You've kind of tackled some of those big challenges, especially in the postpartum space that we've had. If you had to talk about some of the challenges to make some of these big changes, what are some challenges that you had, like that were roadblocks? This wasn't, I think you started this in 2020 is when it launched, but it's still ever changing. And like it took, I know it was years before that. So what are some challenges that to starting something new?
Start small. Do one little test of change. We talk about PDSAs, right? And I think we do PDSAs every day, I think, as nursing, right? We see a problem, we might switch up maybe how we script something to a patient. That's a PDSA. So, we like to fix everything. Us nurses, we want to fix everything, right? But maybe we just take a small change and let's try something small just once or just twice. And I'm a big champion of just do it. It takes courage too, because we don't want to make a mistake. Um, but how do we know things can't be improved if we just don't try small tests of change? So start small and get a buddy, get a champion, get a friend, get people on board. That always helps as well.
Thank you for saying that, because a lot of times what we've heard in the sessions today, sometimes we have to be the first person to initiate a great idea, or, we are the experts. We're dealing with patients. We're on the ground every day with them, and we're seeing how we can innovate those changes to help with prevention and reduction of, the latter outcomes. So with this app and the people who are consulting, what type of providers or people are at the table who are helping to implement this information? Do we have maternal fetal medicine? Do we have someone from ICU? We are seeing a lot of high risk patients as well. Are there nurses? And I think the second part with the question would be the culture that surrounds this community. Are they on the board to discuss what type of, like, to even help with the language that they're testing, right? So you can have somebody who may be Hispanic, Black, Asian, white, Jewish, someone like different, East Indian, just to have a more variety. Has that been considered as well?
Sure, I'll answer the first part of your question of who. It was all of our providers. It was maternal fetal medicine. It was both obstetrics and our pediatricians as well. Definitely nursing. Lactation consultants, they were another big piece because we did get a lot of lactation breastfeeding questions. So we had everybody at the table. Um, and those were all people that contributed to the content of Penny, if you will. It was the same information we would be teaching to our patients in the hospital. That connection continues, and that's what really was the driver of this. We now back then, remember, it was back in 2010, where social media wasn't as robust as it is this today. We wanted to avoid patients using Dr. Google because we know that Dr. Google's probably sometimes not the most evidence-based person or way to get access to information. And then especially now with social media, and that might not be the best information for patients to grasp onto. So we had all our providers at the table. Again, we want to keep those connections after our patients are discharged. We took care of them in the hospital. We want to take care of them after they're discharged as well. The community. So many of we were our test providers, and nurses were test patients. Again, we had a lot of fun trying to break penny. Um, but our own patients were test patients too. We would prompt them and we would educate them like, hey, we're just starting up with this new penny. But rest assured, there is a provider on the other end making sure that Penny gives you the right answers. If not, we will intervene immediately if so happens.
I love to hear that you guys included the community. There's so much literature behind how with these startups are happening and how the success really happens when you have the shared grounds of what initiative they may need and kind of the prompting. So this is great. So do you have advice on how to bring this phenomenal idea and concept into different facilities? How can we get started with this?
Another great question. When I talk about healing at home, I should have mentioned that this is an idea to support postpartum parents after they leave the hospital. But this concept of or idea of the connection between providers and patients can be adopted by any service line. So if say you're a cardiovascular patient being discharged from the hospital, we talked about building that library. You can build that library however you want to build it. So think about how you want to keep those connections with those patients, or the type of patients that you want to keep those connections with, whether it's mother baby, or like on your oncology population. So I think it's important when you hear about healing at home, it can be adopted to any individualized, if you will.
So, Laura, we've talked about two great projects, the Heart Safe Motherhood, Healing at Home, where you've been able to use intervention to like help some of the issues with with problems in your area. But do you have any examples of how you've tried to like use technology or innovation that haven't worked out? And like, have you learned? Because like not every project's going to be successful. So, but then I don't want that to make somebody not want to do a project again. So besides having wonderfully successful projects, can you talk about anything that might not have been successful?
I'm going to go back to the initial project with texting our patient, texting our patients regarding their blood pressure 2 week appointment. That was not successful, but we did take a piece of that that was, and then just kind of pivoted and used it in a different way. Another piece of being successful is making sure you're getting patient feedback. Part of healing at home, we send out surveys. You know, what's working well, what's not working well, and we continuously do that. We want to ever evolve with our patients. And one thing we weren't successful with healing at home, we were giving out too many surveys too close, and our patients are like, wait, whoa, 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 this is way too many texts, way too many screenings. So then we took that feedback and we spaced out screenings, knowing how important it was to um, have patients complete their EPDS scoring. So we can adjust the timing of screenings uh, in order to what the patients need or what their feedback is. So I think it's really important to continue to get feedback from your patients um, in order to be successful in either the current project or if this project would evolve into something else.
What percentage of your patients have initiated engagement with the app or with this with Penny? Yes. What percentage would you say have you guys looked at those numbers of the people who are just discharged from postpartum?
So in current state, we only offer Penny to those patients who are eligible and they're meeting their milestones either at day one of after a vaginal delivery or day two after a C-section. And there's a financial component to that as well. But our goal is to offer it to all patients. In current state, it's again only offered in the English language, but we are also trialing a Spanish version as well. So we would hope to have it a program to be offered to all of our patients, and they can utilize it as much or as least as they would like to. But as we found with our engagement surveys, it's called a Net Promoter Score, which I didn't know what that was. But after they complete their surveys, a Net Promoter Score is evaluated, and that's kind of your customer service score. We are in the 30s. You want your NPS score to be anything above 30. When I looked at other NPS scores for like Amazon's in the 70s. Who doesn't like Amazon? And other payer insurances are in the low 20s. So we're happy at above 30. Um, but again, we would like to offer it to all patients.
And one of my last questions was the amount of time that I can use it. I'm a patient, I'm eligible to use Penny. What is the limitation of when I can use it or have to end the program?
It's a 6-week program. Uh, so we offer it to patients at 6 weeks. And it can also be utilized simultaneously with our Heart Safe Motherhood program. So our high-risk patients that have had preeclampsia or developed preeclampsia after they deliver, they are enrolled in Heart Safe Motherhood to strictly monitor their blood pressure for 2 weeks, but they can also be enrolled in Penny, where Penny will again administer those EPDS screenings at 2 weeks and at 4 weeks, in addition to other screenings for other education and screenings as well. So it's kind of cool. You can a patient can be involved in 2 programs at one time, depending on what's going on.
I'm going to throw one more question out there that you touched on, and I think the listeners might want to know. So, what are the financial complications? Like, why don't this is a great program? Why doesn't everybody just use it and use it all the time? And that's my biggest. I love it, and I wish all patients could use it. But why don't you talk about some of the challenges with that?
So the biggest challenge is finances, money. So current state, initially when we launched Penny, it was supported by I forgot to mention, I'm so sorry. We have an innovation program at the hospital, University of Pennsylvania. So with the launch of Penny, with much of that work was done in coordination with our innovation programs. So when when we finally launched, that funding had gone away. The March of Dimes has continued to fund this program. We would love to sustain this program with our payers.
Thank you for sharing so much. This was a great talk today. If you'd like to know more and would like to read Laura's full bio and resources that she shared, you can go to awhon.org/podcasts. Please subscribe, watch, listen on YouTube or any multiple streaming platforms. We have a lot of variety of great podcasts out there. Recommend an episode to a friend, colleague. Please leave a comment. Tell us about your listening experience. Stay tuned for future roundtables where we can check in with listeners and audiences, amplify your voices. Let us know if there's any topics that you really would like to consider. And thank you again. Be well and stay safe.